It is my pleasure to invite Dr. Hans Hasselbalch, who flew the longest way to be here today with us from Denmark, Zealand University Hospital, Copenhagen University also, correct. So Dr. Hasselbalch will be talking to us about the microbiome and MPNs. Dr. Hasselbalch, the floor is yours.
Thank you very much, Gate. And first of all, thanks so much to the organizers, Dick Silver and Jerry Spivak, and all in the organizing committee for inviting me to this meeting. It is really a pleasure, and it is really a pleasure and an honor to be here. The title of my talk is The Microbiome in MPNs, and these are my disclosures, and this is my schedule. First, the microbiome in health and disease, and the gut as a mediator of chronic inflammation, and MPNs as inflammatory diseases, a human inflammation model, and then also the gut microbiome in the MPNs and future research directions. What are the gut microbiota? The definition is actually all the microorganisms that we have in the gut. The other name, gut microbiome, tells us about the genes on the microbes in the gut. And what are the functions of all this? It helps to digest food, protects against pathogens, and also important in the metabolisms of therapeutics, and provide energy to the enterocyte. And here it is in particular a substance called butyrate. As Angela Fleischmann actually addressed previously today in a wonderful talk, the altered gut microbiota is associated with several diseases, but the headline of all these is chronic inflammation, obesity, type 2 diabetes mellitus, cardiometabolic diseases, hypertension, atherosclerosis, and low-grade inflammation. All these conditions are associated with an altered gut microbiome. And the gut microbiome helps us to regulate the immune system. This implies that when we have a chronic inflammatory state, we actually also have an aberrant immune regulation, and that is of utmost importance in the context of development of cancer. What are then the effects of diet on gut microbiota? As I told you, food components influence both the human metabolism and the composition of gut microbiota. A hypocaloric, high animal fat Western diet, as Angela addressed, change our gut microbiota composition towards what we call dysbiosis. And subsequently, intestinal inflammation leads to leakage of the gut barrier, disruption of the blood. If it is a no inflammatory disease, then disruption of the blood-brain barrier. Conversely, a vegetarian diet rich in fibers is coherent with gut eubiosis, and a healthy condition. Now I will address something that is very important, and just remember the headline and not all the other things. The gut-bone marrow axis, and it tells us that the hematopoietic stem cells, the mother cells, they express certain pattern recognition receptors which stimulate production of blood cells. And if we have a germ-free environment, germ-free mice, then we also have reduced mother cells in the bone marrow, a reduction of the hematopoietic stem cell pool, and myelopoiesis as well. And this can then be rescued by, for instance, other factors that then restore the system again. So we have to realize, and this is not novel information, but we have to realize that the gut-bone marrow axis is a very, very important axis and is a novel player in hematopoietic stem cell aging. The microbiota has attracted increasing attention during the years, and now we also have heard from Angela's talk that aging is associated with chronic low-grade inflammation, what we call inflamma-aging. And aging is also associated with alterations of the microbiota and what I told you about increased intestinal leakage. And this interplay between aging, chronic inflammation, alterations in the microbiota, and how they contribute to aging of hematopoietic stem cells, we do not know much about it, but this is to be explored in the future. What we know today is that there's a role of the microbiome interleukin axis. Interleukin is a particular inflammatory cytokine, a very potent one, and actually this is a key self-sustaining but reversible driver of hematopoietic stem cell inflamma-aging. So, to put it shortly, age-associated microbial dysbiosis promotes intestinal permeability, systemic inflammation, and macrophage dysfunction, meaning that it also stimulates and gives rise to aberrant immune regulation and then ultimate cancer. What are then the consequences of all this? What are the consequences? Have we new therapeutic approaches targeting the microbiota? And I will actually put as a very, very important thing to say shortly, a healthy lifestyle. If we take care of ourselves, then we will have a healthy gut microbiota, and actually saying that the gut bone marrow axis is the starting point for the new therapeutic approaches. And these approaches also, of course, then address to download interleukin-1 signaling in this axis. So, again, I stress that we have aging, and with aging we have chronic inflammation, and the increased levels of what we call ROS, that stands for reactive oxygen species, but that is actually just to translate it, inflammation, may induce silent mutations in hematopoietic stem cells, and others have addressed this so nicely today, so I'll go through it rapidly. And then I will come to the microbiome in the MPNs. And we can have these headlines. The gut microbiome, as the modulator, I will say, is the modulator of health to disease transition. Chronic inflammation, vascular diseases, and cancer, mutations in blood cells, the common link. And so it is. All disease begins in the gut. Hippocrates said it 2,500 years ago, and now we are here again. So actually we repeat just a telling. Before I go into details about our data, I will just recall you our MPN inflammation model, telling the story that we could put in this figure that it starts with CHIP. Several of my colleagues today have told you about CHIP. And this is a precursor stage of cancer development, and here a precursor stage of MPNs. And all this gives rise, chronic inflammation, gives rise to accelerated atherosclerosis, to blood clot formation, and cancer. So patients, you have the risk of several complications. You know this, and therefore it is so important that we speak together. We have to also have interdisciplinary collaboration between the cardiologists, neurologists, etc. And I will come back to this in a moment. We can say that MPNs are inflammatory diseases. They are a human inflammation model, and they are also a human inflammation model for cancer development in the biological continuum from early stage MPN, ET, and in the HER2-positive patients with the risk of transforming to polycythemia vera, etc. But this process is driven by chronic inflammation. We also know that the DEC2 mutation is a particular, you can say, inflammatory mutation, which actually gives rise to accelerated atherosclerosis. And this has been shown in several studies, but just to put in perspective. We have also heard about other mutations. There's a mutation called TET2, and this mutation is also a mutation that gives rise to accelerated atherosclerosis and blood clot formations, and possibly also second cancers. There was, a few years ago in Nature, there was a milestone paper telling the story that microbial signals drive pre-leukemic myeloproliferation in TET2 deficient mice. And this study actually opened the horizon for several other studies on this very important issue, that all disease begins in the gut. So actually in AML, acute myeloid leukemia, the gut microbiota regulates AML via alterations of intestinal barrier function, which gives rise to release of bacteria which contain what's called LBS, and that is a very toxic agent, and this elevates in blood concentration, and then it induces chronic inflammation. So gut microbiota disorders in AML lead to a decrease in intestinal butyrate, and please remember this because this is important when I show you all the other slides. What are the background of our studies on microbiome and MPNs? To repeat, the classic MPNs, they are inflammation-driven diseases, and there's a constant back and forth interaction between the immune system and the gut microbiota. And the composition and the role of the gut microbiota in patients with MPNs is largely unknown. And therefore, we wanted to investigate the gut microbiota in MPN patients. Before we started, when we started, others, and one of them, the pioneer actually in this, is, where are you, Angela? But this is Angela's paper in Microbiology Spectrum. Angela showed in a smaller series of patients that these patients might have an altered microbiome, and we continued then this lesson in our patients, where we published in Blood Advances on 102 PV patients and 42 controls, and also in Microbiology Spectrum on 45 ET patients, and then also the latest one on myelofibrosis patients. And our hypotheses were that the one is that microbiota differs in MPNs, and we have shown this now, it differs. And also, and that is very important, actually the most important message, that interferon alpha 2 tends to normalize the microbiome in MPN patients. And this is one of my key messages. And we also had the hypothesis that ruxolitinib might be associated with marked changes in the microbiota and distinct signatures. And these were just our methodology, and I could rapid through it, but just to pinpoint for you that, of course, the patients were well characterized when they entered the study, with stool samples before and during treatment and after treatment, and samples analyzed using NGS. So the Danish experience with this in our first paper, and do not be disturbed of all these columns. Just adhere to what it says, that the microbiome differs in MPN patients. That was our first message. And actually, you couldn't say that there was much difference between controls and combination therapy. And combination therapy, as you know, we started and published on combination therapy with interferon and ruxolitinib in several years ago, and now we have also done these studies in newly diagnosed PV patients, And actually, we are happy that the French group confirmed our findings in myelofibrosis patients that Combi is a very, very efficient treatment in these patients. So what we found, that patients with PV had a higher observed richness, and also that there were no significant difference between the different groups. Also, we found that patients with PV that have a lower abundance of a taxa called firmicutes, and this particular bacterium, when we have low levels of this, we have an increased risk of inflammation. So agents, or if we have a healthy microbiome, this particular bacterium is actually not that low. Also, we found other bacteria that were higher, Bacteroideales, and also other bacteria. Patients treated with interferon, and that was my key message, that when you have been treated with interferon for a long time, you have a near normal microbiome, likely due to the fact that interferon in mice has been shown to tighten the barrier so that you have not this increased permeability. They tighten the tight junctions between the cells in our bowel. And I think that this is a very, very, very interesting findings to be pursued in our upcoming studies. So to conclude, PV patients, they have a distinct, different microbiome compared to controls, and there were changes in their microbiome saying that they have a chronic inflammatory state, and interferon tends to normalize all these things. So again, patients treated with interferon, they have a gut microbiota more similar to healthy controls. Then we continue to the ET patients, and we have published on 45 ET patients. And just to tell you the story, that it is very similar to the PV patients. And actually, what we found here is that it is the JAK2 mutation that drives the abnormal microbiome, whereas those patients carrying the CALR mutation, they are more near normal. So I will go rapidly through this, just to repeat again that patients with the JAK2 positive ET patients, they have a pronounced microbiota signature, just as the PV patients, and compared to the JAK2 negative patients. And then our latest work that was in myelofibrosis patients, and I can just tell you the story that they have also an aberrant signature. So something is going on here. With the key points in our research, that the gut microbiota in MPN patients differs from healthy controls, that JAK2 mutation drives this difference, and the gut microbiota in CALR patients resembles more healthy controls. You can ask the question, what about hydroxyurea? How does hydroxyurea actually impact the microbiome? Overall, we can say that we have not found any significant impact of hydroxyurea, but hydroxyurea has recently been reported to be associated with an increase in the abundance of a beneficial bacterium, actually tending to be healthy. So it is not that bad, that agent, in this context. What about JAK2 inhibition? Actually, we have not yet analyzed our studies on monotherapy, but we found that several taxa were more abundant in patients on Combi treatment than in the interferon group. But when saying this, it is important that at that time our observation period was too short. So now we have additional studies after 3 and 5 years, because you have to remember that combination therapy, interferon plus ruxolitinib, together with colleagues, we described years ago that actually this combination therapy is the most promising combination therapy ever for treatment of MPNs. Rapid lowering of JAK2 allele burden, and after a few years, actually, the possibility of having a normal bone marrow, and then you can continue with low-dose interferon every second week or third week, and low-dose ruxo as well. So what about interferon alpha and the microbiome? Here we can say again and repeat, interferon treatment tends to normalize the microbiome. It implies a conservation of a more healthy microbiota and a dampening of the microbial inflammatory signals. And in that perspective, it may have a protective role in the gut by ensuring a proper intestinal barrier function. So, interferon alpha tends to normalize the microbiome in MPNs. And now we advance these studies because we take in our project patients with CHIP. As you may know, we have screened 20,000 citizens in Jesus cohort in Denmark and found 600 JAK2 positives, CHIPs. And now we take them into our clinic, and several of them, they develop MPNs, but our issue is to treat these patients as early as possible, because so we shall do with the cancer. We shall not watch and wait. We shall treat as early as possible with an agent that's targeted the stem cell, and that agent is interferon alpha. And then I would just address another agent, that is a statin. I'm sure that several of you are on a statin, and that's a good thing. We have shown that a statin, actually, it prohibits development of MPNs. And statin drugs actually also boost healthy gut microbes. So statin therapy is associated with a lower prevalence of gut microbiota dysbiosis, and that is very important. So our conclusions: the gut microbiota differs between patients with MPNs and healthy controls, and the gut microbiota differs according to mutations, and the gut microbiota of patients treated with interferon is more similar to healthy controls than non-treated. Our future research directions are several. We try to explore the determined factors for clonal expansion and evolution in the chip stage toward MPNs, and also to perform multi-omics in the chip stage, and including microbiome studies, because we really think that these studies together, they will help us coming near the truth in regard to the pathogenesis of these diseases. We will also start treatment with stem cell targeted therapy with interferon alpha in the chip stage. And we, Dick Silva and myself, we addressed this in a paper in Hemisphere 2 years ago, and we are happy that so many other colleagues, they actually support us in this viewpoint, that the earlier we treat with interferon, also possibly in the chip stage, we may have the possibility to eliminate or reduce the clone much more rapidly. And actually, this is just what I'm telling about cancer biology. So, large-scale microbiome studies are needed to investigate the possible role of the gut microbiota in these patients, and then the studies should also include patients with other mutations, as I have addressed previously. Here I have just told you about what happens with our CHIP patients, and as you can see, some of them, they develop increase in JAK2. It's much more easy to see here on the right side. That are patients that have been followed for 7 to 8 years, and some of them, they develop MPNs. Here we have, again, I go back to my MPN inflammation model, telling that we should disrupt this vicious circle as early as possible with stem cell targeted therapy, that is interferon, and then add another agent, for instance, a JAK1/2 inhibitor, or even a non-expensive drug, a statin, because it is quite clear for me and my colleagues that those patients entering, and now I introduce a new term in MPNs, minimal residual disease, implying low burden JAK2 below 1%, normal bone marrow, and then I am a supporter of discontinuation of interferon therapy after 5 to 7 years. And we have several patients which we follow thrice yearly, good health, normal cell counts, and then when they increase in JAK2, I reinstall interferon. And that is, I think, the future. So I will conclude my talk by saying all disease begins in the gut. No, it's not a new telling. And I will again underscore what Angela told us previously. We have to put our patients to advise them on an anti-inflammatory diet. And I really look forward to Angela's studies on the Mediterranean diet. And then also statins might boost healthy gut microbes, as I have addressed. And then, of course, a healthy lifestyle. The dream of the new horizon, minimal residual disease and cure. This is my lovely Pia, and the first patient being treated with interferon alpha and ruxolitinib. Today, 10 years later, normal bone marrow, low burden JAK2, and she gave the impetus to the 50 patients published in Cancer Medicine and Hematologica with Dick Silver in an editorial. I really believe that the future looks bright, and I will just finalize end my talk by acknowledgement of the person that should have given this talk, my PhD student, Christina, who has done a fantastic job with this and defends her thesis in 2 weeks. Also, all our colleagues in Denmark and abroad who have been on this exciting journey and are on board this exciting journey, PhD students and postdocs, thank you very much for your attention.
Thank you, Dr. Hasselbalch, for this very, very interesting talk. I wonder when and how monitoring the microbiome will be part of clinical practice, or at least clinical trials.